Try again. I can see the sound bar going up on my microphone now, so hopefully we're live. Let me just check. Yeah, that's looking good. Okay. And I can hear myself on the stream coming through, so that's good. I think it might only be me that's here though. Let me just repost this. Dee, dee, dee. Oh yes, we've got 2 people watching now. That's good. Yeah, give us a shout on the comments if you can hear us again. Hey, yay, good. Sorry about that. Yeah, I've had to I've had to reschedule some links. Sorry, guys. Ah, good. Thanks, Joe. Yeah, got your message. Yay! Oh, blimmin' heck. Well, thank goodness that didn't happen yesterday because I don't know whether I think I put in our group I was broadcasting to this massive physio group in Romania, and they thankfully I didn't have to learn Romanian for it. They really mad. I was translated into three different languages, and yeah, I was be interesting to actually hear what I sound like as a Romanian. I might have to try and get the Romanian translation. But welcome. Yeah, sorry a bit late, and yeah, some issues with the mic, and then it just wouldn't go back on again at all. So I've had to refresh everything and start again. But that's the joys of going live, I guess. So let's get going because we're running a bit late already. So we last time had a look at the muscles of the lumbar spine, and hey, we're back. We're back. Yeah, it's one of those where everything is perfect when you set it up. I test everything every single time, press live, and then nothing's happening. So there we go. So yeah, last week we had a look at the anterior musculature. So we were looking at this and the layers of that anterior abdominal wall, and then how that links in with inguinal hernias and the inguinal ligament at the bottom. So that kind of forms the floor of that anterior abdominal wall, and then all of the different layers. So transverse abdominis, which was the deepest layer, and then we just move me up there. We were looking at these structures here and talking about this arcuate line, and then down into the inguinal canal as well. And whereas you might have seen this image a number of times before, but not really noticed that there are those divisions within the aponeurosis, so really flat tendons. And obviously they meet in the middle, so that there would be a gap on this side and a gap down here as well. So you can see why we get inguinal hernias, and you can see why we get these abdominal hernias as well. Because especially lower down in the abdomen, because of there's less connective tissue as you get lower down. So transverse abdominis, which means across the abdomen, that was the deepest of the layers, and then we had internal oblique, and again these kind of form into that inguinal ligament area as well, and the wrap the rectus abdominis, those six-pack muscles within their connective tissue, and then the external oblique, which goes over the top of everything. Then you'll have your subcutaneous fat layer on top of that. But then in between all of those layers, you have the rectus muscle. So we were looking at these. So underneath the rectus abdominis, you'll have uh, it's uh, it's weird that they're on some and not others, and different programs as well. I think some people or some books will include it, and some won't. Yeah. Um, Yay! Well done, Penny. You haven't missed much. Sorry, Penny. We've only just we're just doing a recap of last week. So yeah, the transverse abdominis and half of the internal oblique went underneath the rectus abdominis, and then half of the internal oblique went over the top of it, with then the external oblique over the top of that. So we've got these different layers depending on the different position. And then, as I think it was Becky posted in the group, that line, that arcuate line, is where the blood supply gets to the lower abdominal musculature. So yeah, so that was really good, and thank you for finding that out. So yeah, we've you can see where the weaknesses are within the abdominal wall, why we get hernias in certain places. And if you have a look at the abdominal hernias that you get, usually around the umbilicus, so obviously another opening through to the outside world, and around the rectus sheath. So you'll often get herniations there as well, and linea alba might be another place where you get them, and obviously diastases recti, where that linea alba and the rectus abdominis start to come apart. So you can see why certain things happen in certain areas. Some people may be predisposed to these particular issues. So that's what we looked at last week. A bit of a recap there. And what we're going to have a look at now is kind of like finishing off the rest of the structure, so the rest of the cube around that lumbar spine, so that next week we can start looking at the nerves. And we've done in detail the sacral plexus before, and there's part of the sacral plexus that comes from the lumbar spine as well, and we had to look at that previously. So we're going to now connect in the lumbar plexus onto the sacral plexus to bring everything together, so all of the nerves for the lower limb. So this session will be a prelude to that. What is also good with this session is it shows the connection between the abdominal cavity and the thoracic cavity. So when we start looking at organs and the different organs that are in different places, then you can see where everything connects. And obviously where, again, between the abdominal cavity and the thoracic cavity, there are gaps, because things have to go through those gaps. You struggle without a blood supply if you couldn't get your aorta through your diaphragm. So and you'd struggle to digest food if your esophagus didn't go through your diaphragm. So we've got these holes that are in the diaphragm, and that's the separation between the abdominal and the thoracic cavity. And those holes are weak spots, again, for some people more so than others. And you can have what's called a hiatus hernia around those regions. So we've got all these little kind of gaps within the various sections of the body. So we've had a look at the gap around the inguinal region, around the anterior abdomen, and now we're going to have a look at the superior part of the abdominal musculature as well. First, though, hopefully everything works when I click on the videos now. I have tested. I promise I don't just turn up and hope for the best. I do prepare and I do test everything beforehand. So we're going to have a look at the posterior muscles first of all, and we've got some superficial posterior muscles and then some deep posterior muscles. So we're going to have a look at the division between the two. So the posterior muscle, or the first set, some that we've seen before. So we've had a look at these before, the erector spinae group, And we looked at these because they come from down here in the sacrum. So let me just get rid of that so we'll be able to see everything. Yeah, so we've had a brief look at these previously, and we'll just have a bit of a recap of these. But this will give you um, a good kind of awareness, appreciation, if you like, of the layers to be able to palpate and access certain muscles. So we're going to have a look at these ones first, but then as we go deeper, we're going to have a look at psoas and what else? QL as well. So and again, I mentioned QL a few times last week. And yeah, the amount of musculature you have to get through to get to these muscles, and when I was first taught manual therapy, we were like, yep, you're on QL or whatever it is, but it's very unlikely to be the case. So this is the erector spinae, and it's three muscles all in together. So it's iliocostalis, and if you think about the names of them, ilio is to do with the ilium, and then costalis is a name for a rib. So iliocostalis goes from the ilium to the ribs. Okay, longissimus is just long across everything, and then spinalis is closest to the spine. Okay, so we've got this group of three muscles that are they look fairly distinct here, but when we see them in a second, you'll realise that they're not. So everybody, fingers crossed. Let's hope these videos work. Okay, so posterior muscles, erector spinae group. It's not working. Okay, bear with me a sec. Don't you just love this stuff? Right, okay, let me get this one. Erector spinae. Let me just see if I can find it another way. The anatomy and like you'll have no idea how many videos I have lined up here. Here we go. Muscles. Luckily, I kind of order everything, so it's not too bad. Okay, let's have a look at that. Hopefully, is that going to get rid of that? Bear with me a second. I'll just try and get these up. Oh, there we go. Yes. Okay. Phew. So bear with me. Might take a little bit of time to get these going, but once we get them going, they should be good. Okay. Yeah. So this is the picture that you've just seen on the PowerPoint slides, and this is what it looks like in real life. And again, we've kind of had a look at this before. This is one of those videos where hopefully you'll be able to pause it and you've got all of the details about these muscles here, and then you've got the images of them as well over the top. So if you're revising for any exams, then this should be useful. So we've basically got three muscles in one. They're listed as separate muscles. And again, there's a rude way and to remember these, and that it wasn't me that came up with this. I promise that this was actually one of the girls on my course. I like sex. That's how she remembered the erector spinae and the way that they go. So there you go. Could change that just to I like spines if you're going to be a little bit more less provocative. So iliocostalis, so from the ilium to the costals. And then longissimus is the long one in the middle, and then spinalis is the one that's closest to the spine. So obviously you can see the sacrum just there, and the edge of what would be the ilium just there. So let's have a look as we go through. Yeah, so these sections on here, we're going to have a look at these in a bit more detail as we go up into the thorax. But these are your ribs. Okay, so you can see the rib cage, and then the intercostal muscles in between there as well. So yeah, it's got a shared tendon, and then you can see kind of slithers of tendon as we go through. So spinalis, then longissimus, and then iliocostalis, the shortest of them, and the most lateral. So yeah, you got the posterior or the dorsal sacrum, so it attaches all around here. So this is a really, really long muscle attaching onto the spinous processes and the iliac crest. And then spinalis, just move me out here. So spinous processes of the thoracic spine this time. This one, which kind of makes sense, doesn't it? And then longissimus, the one in the middle. This is the lower 9 ribs and the transverse processes. So again, you can see it's slightly more lateral than the spinalis. And then iliocostalis, lateral again. Okay, so on those bottom parts of the ribs and all the way down. So if these muscles contract, you get extension of the spine, hence erector spinae. Okay, so the erector spinae group. So that is these. So that's what these look like in real life. And again, you can see the differences. Now I know for a fact that this video is not working either because I pressed on that one just to see. So let me bear with me a second, and I'll just find this one too. Just go to that. So muscles, multifidus, there we go. And then hopefully this one will come through. Ooh, is that it? No, let's just get, there we go. Okay, is that the erector one? That looks like erector spinae again. Bear with me a sec. Just get rid of that. Oh, okay. I think that might have just done it. Bear with me a second. Let's see which one this is. Okay, let's get rid of that. Oh, there we go. We're sorted. We're back on. Okay, so multifidus. This is one that we had a chat about a couple of weeks ago because we had a bit of a conversation about this when we went to the anatomy labs. And there are some tests that you can do to palpate this muscle, and this is the thing. Okay, so if you think about last week, we looked at the layers of the abdomen, and around the sides there, you've got the external oblique, then the internal oblique, and then the transverse abdominis. Okay, and there is a test that Stuart McGill recommended, where you palpate either side of the rectus abdominis for transverse abdominis activation, and then you palpate the multifidus at the back, and you see whether there's a co-contraction between those two muscles. So if you think about those layers that you're feeling through on the front of the abdomen, and trying to isolate transverse abdominis palpation through the front of all of that tissue, you have got no chance. Couple that with being able to palpate this muscle. Now these here, these are underneath your erector spinae. They're also underneath your lats. They're underneath your thoracolumbar fascia. So that these are really, really deep, right close to the spine. So being able to palpate multifidus and TBA at the same time, you've basically got no chance of being able to isolate those structures. So what you could say is that the muscles on the front of the abdomen are contracting, the ones on the back of the spine are contracting, but there is no way that you could say that it's this particular muscle or that particular muscle, and there is then therefore a delay in either one. Okay, so it's virtually impossible to do this. We can't even see it, and this has been dissected. So how can someone palpate it yet? So that's what the anatomist said when we questioned him, and Sarah was there with me. He heard him say it. Okay, so yeah, we struggle to see these on dissection and be able to work out which one's which. Yeah, so it's really, really unlikely that we're doing that when we're palpating through the skin and all the other tissue. So if you have a look at these attach on the kind of side of the spinous processes and then onto the transverse process. And then there are deeper muscles. Again, we've got the rotatory group, but these are the multifidus muscles. Okay, so multifidus. So you can see here, they're kind of run in an oblique fashion down, and this is in the thorax. but they go all the way down the spine from the cervicals all the way down to the sacrum. So that's why they're included in the lumbar spine as well. Okay, cool. So that's your multifidus. So if we think about it, we're building up the posterior muscles, and then we've got this one. Now I've mentioned this a few times, and it's a classic one for massage therapists, of which I am one, and I used to teach this stuff as well. So apologies to those that I did teach over the last sort of 15 years. I wasn't accurate when I very first taught it, so now's the time to make up for it. Is there an exercise or test for this muscle? I'm assuming that you mean multifidus. Exercise, it will be involved in extension. Again, you won't be able to isolate it because all the other muscles around it will work as well. And it'll be involved in rotation as well. Yeah, so any kind of rotation and extension, multifidus will be helping out, definitely. But again, being able to isolate it and only working that muscle, no chance. So quadratus lumborum. So we've got this quadrangular muscle attaches onto the lower rib, transverse processes, and then onto the iliac crest as well. And when the two contract together, we get extension of the spine. When you lift one leg, then the QL on the opposite side will stabilize your pelvis. Okay, so it's used during gait and during running. If you just standing on one leg without even any weight, your QL will activate. And if you side bend, then to that side, then your QL will also bring about that movement. So that's a really good point. Yeah. So if we are writing treatment notes, what can we say instead of treating QL? It's really good, I think, to be as broad as possible. I will still use that in my notes, because just in case anybody else thinks, well, what did he work on? But if you were going to be really accurate, then you would say that I've done manual therapy or whatever technique it is to the overlying structures of QL, and or even the skin over QL, because that's basically all we touch. So I'm a lot broader with my treatment notes rather than specific, especially with manual therapy. So with exercises, it's a lot easier to say that I did 10 repetitions of lateral flexion, whatever it is. But yeah, in terms of treatment, I usually put soft tissue massage to region over QL. Yeah, and that'll be it. Yeah, it's really as simple as that. So quadratus lumborum has got different direction of fibers at different parts, so they've got different connections. So you've got iliocostal fibers that go from the ilium to the ribs. Then you've got iliolumbar fibers going from the ilium to the lumbar spine, and then you've got the lumbar costal fibers that go in this direction. So they go crisscross across here, straight up and down, and then across to here. So it's a bit of a mishmash of fiber direction. And everybody cross their fingers. Oh, hello. There's all sorts going on now. Okay, I've got too many videos. Right. So let's get rid of multifidus and let's have a look at QL. Hey, it's working. Okay, so this is QL. Let's just go back to the beginning. Now, this is really cool. So this is the edge of your thoracolumbar fascia, just here. And remember, that's where your external oblique, internal oblique, and transverse abdominis all attach into there as they wrap around the abdomen and come to the front. Okay, the muscles we've just had a look at are on the other side, so they're on the spine side. There's your lumbar spine, So you can just about see the discs poking through, and then the vertebral bodies in between. So let's have a look at where the QL is. So there's your edge of your thoracolumbar fascia. This is the edge of your rib. There's the iliac crest just around there. Lumbar spine. There's your QL. Okay, so it's right next to your spine. Okay, so anterior to the erector spinae muscles and the thoracolumbar fascia. Okay, so iliac crest, transverse processes, and the 12th rib. So that is a really, really deep muscle. And one of the ways that we used to teach to be able to access QL was side lying. Yeah. But again, if you think about in a side lying position, the structures that you've got to go through, and then look how close that is to your spine. Okay, it's really, really close. So there's going to be guts and stuff in the way. So again, do we need to be really, really specific with what we're doing when we're doing manual therapy? No, not really, because we don't know that we're that specific. It's unlikely that we are, but we still have an effect on that area through via the nervous system. So I think one of the biggest mindset shifts for me is trying not to kind of brutalize muscles. Okay, and I don't have to get on them. Do you know what I mean? There's no way you're going to get on them anyway because of all the other tissue in the way. But that is a really, really, really deep structure. You're going to really struggle. Do we talk about the ligament for this? Just pop that up there. What do you mean, Penny? Which ligament? And yeah, if you give us a bit more detail, and then I'll hopefully be able to answer that for you. So that's QL, and then see, I've usually got an automatic thing. I've got this pedal that goes through the slides, and that's not working either. Oh dear. Okay, so psoas just here. This is This is obviously attaching onto your lumbar spine. One of the deep posterior wall muscles. Okay, so works all the way along that lumbar spine. And attaches down at the hip. And we've had a look at the hip end because we saw it as it passed underneath the inguinal ligament. So we've seen that before. So onto the lesser trochanter. But it starts up here. I'm guessing you mean the origin of the QL. Is that right? Yeah. So let me know if that's right. So transverse process L1 to L4, and then vertebral bodies of T12 to L5, and this also attaches onto the discs. Okay, so just move me out of the way because I'm in the way. That lovely muscle. There we go. So all the way along there. So one of the really deep structures on that lumbar spine. So let's have a look at this one. Yay. Okay, so there's your QL. Okay, just there. There's your spine, and then there's your psoas. So you can see QL just poking behind the back there. There's your psoas muscle there. So again, this is one of those where you can pause it, hopefully, and you've got all the information there. So you've got the image from the PowerPoint, you've got the origin insertion, and you've got all of the attachments, and you can see it there. So hopefully that will be useful if you're studying. So that is what it looks like in real life. Okay, and yeah, it's really, really quite thick muscle if you are active. A lot of the cadavers we see in the labs, they're quite small. They're usually people in their 80s, but these are usually quite chunky muscles attaching all onto the vertebra and the discs. It runs over the sacroiliac joint and then underneath the inguinal ligament, and we've seen that before, attaching down onto the lesser trochanter. Okay, so you can see the kind of line of pull of that. There's your iliacus muscle joining into it, strictly not lumbar spine, but obviously they've got a conjoined tendon, and they both then attach into the lesser trochanter. But you can see the attachments of the both. Yeah, so just join in there. just before they go underneath the ligament. When we have a look at the diaphragm in a second, and we've seen it before as well, there is a fascia that overlies this area, and that's important because that fascia blends into the diaphragm. Okay, so we'll have a look at that in a second. Cool. Okay, so that's your kind of posterior edge, your posterior wall of the of the cool. Sorry, I've just seen your other messages come through. I was just waiting for it. Of the abdominal wall. So origin, ilium, yeah, cool. Okay, yeah, let's have a look. So yeah, the insertion point here. Okay, so this is still really anterior. So you've got again transverse abdominis just behind this QL. Okay, so that's over there, and that attaches to the iliac crest as well. Then you've got internal oblique, and that's going over there as well. Then you've got external oblique, that's going over there as well. You've also got thoracolumbar fascia over here, so that's where your lats attach, so that's coming over here as well. I think that's pretty much it. Yeah. So we've got a lot of structures. Ooh, tried to move me out of the way, move the whole thing. We've got a lot of structures that overlie here. So again, if we're palpating the ilium, then we could still be, well, we will be palpating other structures as well as QL. Okay, so there's lots of other layers that are in that region as well. So again, we can't be really accurate with our palpation there. Okay, cool. So superior muscles, here we go. This is the last one. Good timing as well. So everybody, hopefully, as just put my head there, top of the spine. Everybody there, everybody on this, hopefully realizes that the diaphragm is what helps us breathe. Yeah, so it does it passively, and it is this nerve here called the phrenic nerve. This is an autonomic nerve, so it's automatic. We don't need to think about breathing. And it comes from C3, C4, and C5. So it's C3, 4, 5, keep the diaphragm alive. That's the way to remember it. And there is a very thin nerve that attaches onto the top of the diaphragm, and it runs down the thorax. Okay, and we'll have a look at this when we look at the nerves up into the neck. But the top of this is innervated by that phrenic nerve, and that controls your breathing. So this is why neck injuries in rugby, swimming, whatever it is, diving into the shallow end of a pool, that's why those are really dangerous, because if you injure that C3, 4, 5 region, you can injure your neck, which will basically switch off your breathing. So that's why if you've ever done pitch side first aid, we do stabilization of the C-spine, and we're really careful with someone's neck if they've had a suspected neck injury. So yeah, what else? Yeah, so draws down, and when it contracts, draws down to bring air into the lungs. Okay, so it's kind of like a negative pressure. So it's sucking air in from the outside, and then as the diaphragm domes back up again, it will then push the air out, and then we'll breathe out. Okay, so let's have a look at that in action. Hopefully, get rid of that one. Yay. Okay, cool. It's nice when it works. Okay, so here are your ribs. So again, these are called your costals. So that's why the muscles in between, just do that. That's why the muscles in between are called intercostals, because your ribs are costals. So you can see the intercostal muscles just there, and when we get to the thorax, we'll look at those in detail. So there's an internal, external intercostal, and then there's an innermost intercostal as well. So we've got all these different directions of costal, intercostal muscles as well. That's the costal arch, which is the bottom part of your ribs, and then your xiphoid process, which is the bottom of your sternum. So all of this provides attachments for the diaphragm, and it's literally just tucked inside your ribs. So if we have a look here, this is your diaphragm here. Okay, there's a central tendon where it all attaches, but this is all the diaphragm muscle, all the way around there, all the way around there. See all the white stuff? Yeah, so it's attached all the way around, and then there's a central tendon in the middle. And what you might be able to see already, if I just pause that there, we've got these openings here. Okay, and I talked about the tubes coming down and the tubes going up, and these being weak points between the abdomen and the thoracics. This is why, yeah, we have to have them there, but it's an area where things can be herniated. Okay, so the diaphragm attaches all the way around, apart from this opening here. Okay, so all the way around the spine apart from that little opening there, and you'll see why in a second, because you'll see what comes through. So there's a little gap there, and this is where it attaches. So we're just going to take away half a rib, or half of the ribs, and then have a look at the back. So that is the line, you'll see it in a second there, so that's where it attaches. So just underneath the zippy sternum, the xiphoid process, all the way down those costal cartilages and all the way to that 12th rib. Okay, all the way around there. And then from the 12th rib down to L2, we've got an attachment on both sides, and that's these here. So that fascia there, that's overlaying the QL and the psoas. So can you see how it all kind of connects together? So the QL is like fixed to the diaphragm. That's your vena cava opening. Let me just pause that there. Just go back a sec. So that's your vena cava opening. And if you've not heard of the vena cava before, that is your deoxygenated blood. So the main vein going back to the heart from the lower extremity. So that would be your inferior vena cava that will come through there. This one here is an esophageal opening. That's where your esophagus will come down and then connect into your stomach. So the next one along, there you go. So that's the esophageal hiatus, and this is where you can get a hiatus hernia. So bits of the abdominal cavity can go up into that space, okay, and sometimes it kind of domes just underneath here. So when someone does a sit-up, it kind of pushes through this bit here as well. Okay, and then we've got the last gap here, and that's your aorta. So the descending aorta coming through there. These bits are all called the crus, and there's a bit of a kind of X shape across the two. So all of those holes are kind of given extra support with that crus. Attaches down to L2 and L3, so that's the lowest point of the diaphragm, is the mid part of your lumbar spine. We've got another arcuate area, so that's the arch ligament just there, and this is the join between the esophagus and the aorta. And this is what happens when you breathe. So when you're breathing in, there's the dome of the diaphragm, so obviously the lungs will be here, and then that pulls down, sucks air into the lungs, and then when you breathe out, the dome re-establishes and the air comes out. Okay, and that's it. Wow, that was eventful. Sorry about all the faff at the beginning, but now we have done anterior abdominal wall, posterior abdominal wall, both the superficial structures and the deep structures. We've done the pelvic floor before as well, so there was a whole video on the pelvic floor. So that's the floor of the abdominal cavity, and now we've done the roof as well, which is the diaphragm. Okay, so we've done everything around there. So next week we're on to the nerves. And we're going to have a look at the lumbar plexus and how that then joins into the sacral plexus, and then obviously the innervation for everything in the lower extremity. So hopefully everything will be good next week, and I will see you live at 10 o'clock next Monday. See you then.